Right, well, welcome everybody to this British Pain Society Older People Special Interest Group webinar. It would be great if we could have the introductory slide up in a few minutes, but what we're going to do is wait a minute or so because I believe people are joining us. People are sorting out their connections. So we will, if you can hold on for a few more moments, we will do formal introductions once we have everybody on board, and I will tell you a little bit more about what we're going to talk about this afternoon. Yes, so we're hoping that everybody's internet holds up and we have a good, we're going to record this as well. So just bear with us for a few more minutes, a couple more minutes until we've got everybody on board. Okay. So I'm just going to give it till 2 minutes past, and then I will do formal introductions. Esther, who is our host today, will share the initial slide, and I will talk through what we intend to discuss. Yeah. And I hope that the weather is clement wherever you are joining us from, in parts of the UK or parts of the world, or hopefully very, very interested in older people, or have come along to be inspired to think about the needs of our ageing populations around the globe. Okay, right, it's 2 minutes past 4. I think that's probably the right time to formally introduce this British Pain Society Special Interest Group webinar. So Esther, who is kindly hosting this, she is part of the team from the British Pain Society Administration who is recording this session. So please note this is being recorded as well. So first thing to say is the British Pain Society is a charitable organisation which supports the professions related to pain management, all the different health professional groups across the UK. It's been established for well over 50 years now. It was one of the first pain societies in the world to be established. And is also affiliated with EFIC, which is the European Federation for Pain Chapters, and also with IAS, which is the International Association for the Study of Pain. And the purpose of this webinar today is to promote the work that goes on related specifically to older people's pain management. And older people, the phenomena of being old is going to occur hopefully for all of us. If you live in China at the moment, the population of people aged over 65 is shortly to hit 300 million. That's a scary prospect when you compare that to the current population of the United States. Do we have a second slide, Esther? Right, so this is also to mention that we have, there's an annual conference which is being held in Nottingham this year on the 4th of June, from the 4th to the 6th of June, and that's the annual scientific meeting in Nottingham of the British Pain Society. And there will be information, if you wish, more about that from the organisers here today about how to attend and how to learn more about pain management as a whole. Right, so I'm going to move on rapidly to introductions to my two panellists who have been known to me for a few years now. The first panellist, I'll just take a quick overview, is Professor Patricia Schofield, who was one of the pioneering nurses in pain management. She has been expert in pain management for probably 30 years-ish, possibly a little more, I don't know. But she's a professor of nursing at the University of Plymouth. She's held many esteemed positions, both in nursing as a professor, but also in regard to pain management in IASP and in EFIC and in the British Pain Society over a number of years. Our second contributor today is Dr Lesley Brown, and Lesley works at the University of Bradford in a unit that specialises in older people's concerns, in particular related to frailty. So the first presentation is going to be about Pat Schofield's work surrounding dental pain. So I think, Pat, over to you whenever you're ready.
Thanks, Margaret. I'm just going to share my screen. Sorry, I just need to go back a few slides. Stop sharing. There we go. Can you see that, everyone? There. Can everybody see that? Margaret, can you say yes? Because I can't see.
No, unfortunately, I can't. I can only see you at the moment, Pat. We did see your presentation briefly, but it's disappeared.
Oh, excellent.
And we have people joining us from, I'm sure, from parts of the UK. Please use the chat facility if you have any questions. So while Pat's organising a slide, you won't be able to talk because of the amount of people that are joining us today. Pat, we can see the presentation now. Yeah. So if you do have any questions for Pat, Pat is happy to take email inquiries. She's going to put her email on one of the slides, I think. And but if you do have any for during the webinar presentation, do please use the chat facility, and we will pick those up at the end of the talk. Thank you. Over to you, Pat.
Okay, so hopefully we're all on target now. I do love technology. Thanks, Margaret, for the introduction, and thanks for inviting me to talk. I'm going to share some work that we've been doing over the last 2 years now, 2.5 years. We started off with a small project funded by the University of Plymouth, and then this led into a much larger project which was funded by Pern Charitable Trust, which is a local Plymouth charity. And it's a collaboration between myself and 2 profs from the dental school. And then we have 2 research fellows who are also involved in the project. And basically it is around dementia and dental pain. And how this happened was obviously my interest is pain and dementia, and I was talking to one of the profs in the dental school, and that's how we linked up and decided to do some work in this area, being aware that there is very little research looking at dental pain in people with dementia. And we were particularly interested in focusing around the care home setting. So I'm going to talk about generally pain in older adults, which has always been something of interest to mine, and then I'll present the information on the dental pain study. So as you know, I'm sure, and anybody who's heard me talk before will know that I talk about how we are seeing this increasing ageing population. So over 10 million people in the UK are over the age of 65, and that's going to increase to 19 million by 2050. It's interesting that pain and ageing has never really been high on any of the agendas. I remember talking in Australia, the World Pain Congress, a few years ago, and pain and ageing was the last topic on the last day, and I think we had about 6 people attend. So we really do need to get our act together around pain in older adults. There's currently 3 million people over the age of 80, and that's going to reach 8 million by 2050. And as the pensioner population rises, the younger population in the UK is actually decreasing. So our ability to care for older adults is limited really to the limits of social care rather than sort of families and so on. Chronic pain affects 20% of adults. I guess you all know this, and as we talk about the older population, we know that this rises to 62% over 75 years. And we see many diseases associated with chronic pain in the older population. Things like arthritis, diabetic neuropathies, and things like that. And there are many risk factors associated with getting older as well. So reduced activity, reduced mobility, comorbidities, and of course the reduced social networks that we see amongst older adults. So that in itself will also precipitate the sort of development of chronic pain. But as I said, dental pain is something that has not really been well addressed. Chronic pain is associated with poor general health and increased pressure on resources. So carers, informal carers, the NHS, social care, benefits, etc. And in older adults, it's often underreported. We did some work a few years ago talking to older adults about their pain, and they don't like to complain. They assume that healthcare professionals are the experts and they will know that they're in pain. But remember, the caveat to this is that what we're talking about here is a 30, 40-year demographic. So it's not that older adults fall into the 65 to 70 age group, it's 65 to 95. And we see things like isolation, disability, and depression. In care homes, we also see a significant number of people with dementia. So over 900,000 people have dementia in the UK, and this is increasing to 1 million by 2030 and 1.6 million by 2050. This is the problem that we are about to face in the UK and all across the world. 70% of care home residents have dementia, and we've got over 11,000 care homes in the UK. Over 8,000 of those are dementia specific. So we've got this huge population of older adults with dementia living in care settings that we have difficulties identifying the pain from changes in behaviour. And dental pain is an area that is particularly overlooked. In 2012, the British Dental Association emphasised the need for dental care services for care home residents. And in 2023, a recent report published suggested that there have been some improvements in awareness of oral health, with knowledge rising from 61 to 91%, but it also highlighted at the same time the need for more education of staff. 40% plus of staff working in the care home setting had not received training on mouth care and oral health. So the aim of this 12-month project was to identify solutions to better assess and manage pain, dental pain specifically, in care home residents, particularly living in Plymouth, because it was funded by a local charity. We had 4 main objectives. We wanted to bring together stakeholders from all of the sort of key areas. So geriatricians, dentistry, nutrition, nursing, social care, technology. And we had partners as well in the US who were involved in this. We wanted to look at the literature and the policy documents and see what was happening during this series of stakeholder groups. We wanted to agree a consensus statement of what could be done in the future to help improve oral care in care homes, and to identify solutions that could be evaluated in the future with further funding. We developed a service user advisory group to develop a proposal to lead on from this piece of work. So over the 12-month period, we held 3 online stakeholder events via Zoom. And this was to ensure that we obtained the views and perspectives from everybody involved. And we included experts by experience as well. And we took on board this Delphi approach to data collection. So the first event included 25 participants, and that was dental professionals, dementia experts, pain experts, care home managers, care staff, and international academics. And what we did at that first meeting was we presented the findings of our systematic review that we'd carried out in the first project. And we presented the results of the scientific literature and any relevant health policies to identify potential solutions from this group and to identify what were the challenges in delivering dental care for people living in care homes with dementia. And this was interesting because following this event, we were contacted by care home managers who changed their practice even at that early stage, because they had previously referred residents to hospital settings for dental care, which of course made their dementia worse. And they changed their practice to bring dentists into the care home setting. So that was quite a significant achievement from that early stakeholder meeting. The second one was caregivers, and we had 10 caregivers, and these were generally informal carers, and we wanted to engage with them to find out what their experiences were, and these were caregivers past and present. And then the third event was 40 participants, and again that was the whole multidisciplinary team: dental nurses, speech therapists, dental hygienists, dentists, geriatricians, care home managers, public health, and informal carers. And what we wanted to do was to bring everybody together to demonstrate the results of what we've done so far and to develop a logic model. And this is our logic model. And you can see some of the key things that we identified. So mouth care rarely prioritised. And I don't think this was a surprise at all, because we know that in any healthcare setting, mouth care is not always seen as a priority. Lots of things around behavioural changes and lack of skills and tools to assess pain, even though for years we've been promoting pain assessment tools and the use of them in care home settings, and many care homes use pain assessment tools, but there's still this lack of confidence about using them to identify behaviours that could be pain. And of course, then if you go down the dental pain, the oral health pain pathway, then it's even more complicated. So you've got somebody with dementia, you've got to be looking in their mouth, which can be quite challenging for the resident and the member of staff. Treatment can be complex. I mean, we were just talking earlier about the ageing population and the complex needs of older adults now, with sort of really complex dental procedures having been carried out in their lifespan. Dental implants, bridges, all these sorts of things that people have had put in their mouths as they've got older. And this becomes challenging of how to deal with them when you're dealing with somebody who can't articulate or communicate. Informal carers wanted more involvement. They wanted to know about what education would be available. There was a need for more data sharing across organisations between care settings, the NHS, and dental services. And there was a suggestion of dental champions within care home settings, which was quite interesting as well. So what we wanted to do was to look at particular interventions that could be developed from these stakeholder events, and to work on developing these interventions within the next stage of the project, which we would seek further funding to do. So what we were aiming to do was to increase this awareness of dental issues in the ageing population, to bring on board the issues around dealing with people with dementia, such as assessment and challenging behaviours, and try and work together to develop some kind of intervention that could be tested. So the findings from this stakeholder event, well, pain assessment, real challenge for care home staff, real challenge for dental practitioners. One of the things they wanted to use, or they were keen to use, interestingly, was pain diaries. So we actually keep a long-term record of the pain, which is quite contrary to what we promote in the sort of national guidelines for using things like the Abbey scale to assess pain intensity. As I said, they wanted to see oral health champions implemented across the piece in care homes, and dental dementia champions as well in dental surgeries. Any barriers to access of dental services they wanted to see addressed, and I think this is a major challenge for dental services going forward, as we all know, dental services have their own challenges. Prevention of oral problems is crucial, because once oral problems develop, as you well know, we see things like residents not eating, not drinking, which leads to other major comorbidities. Lack of dementia-trained dentists. Improved knowledge was desperately needed, and there is a lack of published literature. Possible digital solutions. Our partners in the US have sort of digital education and ways of using digital solutions. And this was something that our care homes across Devon and Cornwall were quite interested in. From event to identifying preventative measures, a dental pain risk assessment tool, ability to recognise and communicate pain effectively, which goes back to the education thing. Streamlined access to dental services, and to be able to distinguish between dental discomfort and dementia progression, which sort of leans towards some kind of dental identification tool. Lack of information and support for caregivers. A lot of the caregivers were identifying things like, I don't like to brush my husband's teeth because he gets upset and distressed. So what do I do about it? Using an electric toothbrush can be quite distressing for people with dementia. Unfamiliar tools for mouth care, and the need to be flexible in the use of interventions. And for care home staff, it's about time and resources, like everything else. From the sort of consolidation event, what we wanted to do was to provide something that was sustainable and accessible training programme, and to push oral health care into the policy agenda, particularly for older people, and particularly for older people with dementia. Clear pathways of care and user-friendly training packages. The Welsh Government apparently have dental training packages for people with dementia in place, and we need something like that across the rest of the UK. And better links and communication across all professions. We sort of pulled together this lovely diagram which brought all of these things from informal carers and professionals as well. We use this to promote improvements in dental care. So effective mouth care. Some days the person might be receptive to mouth care, but other days they might not. Cost of oral care can be a problem. Fluoride toothpaste, for example, the cost of, and unpaid carers feeling that they have less authority than paid carers. And from healthcare professionals, a need to build the relationships, no clear guidance on implementing this NG48 policy for dental care in older adults, lack of time and training, and actually preventing diseases from getting worse. So mouth care matters. We've published our final report. Our systematic review has been published. That was a year ago. And we're waiting to hear, we did a report on working with the carers, the informal carers. So we're waiting to hear what's happening with that publication. We have developed a further study and we have looked for funding. This is a co-design project that we've worked with informal carers on. Unfortunately, it was rejected from programme grants last year, so we're looking for other funding. And we want to influence policy, so we have started a dental pain and dementia campaign, but it's very uphill with that. So just a thanks to the funders and also everybody who was involved in the project. I've put the reference for the systematic review is on there and my email is on there. Unfortunately, I can't stay beyond 5, but I'm more than happy if people have got questions to email me, and I'm quite happy to share the slides. So that's it from me.
Thank you very much, Pat. That's a very, very interesting project, and it's quite, I think, alarming. The sort of the level, the prevalence of dental problems in our aging population and in the care homes in particular. So I do think that that's something that needs to be picked up and taken further. Thank you very much. We've got a couple of questions. We've got from Pete Moore has asked, would it be useful to train carers in care homes to support and coach residents to learn supported pain self-management skills? What are your thoughts on that?
I think the whole issue of pain in the Asian population is challenging. I totally agree, Pete. I think there is an appetite amongst the ageing population for self-management and improved self-management. And I know that you and I, Pete, have talked about your pain toolkit for self-management. So yes, the challenge, I think, in care homes is that 70% of the population have moderate to severe dementia. So, you know, working on self-management may not be the way to go constantly, if you like. You may have periods when you can work with the resident, but I think it would be quite challenging. So I hope that answers your question. And the next question, I think, as well about hygienists visiting care homes. I think there are some areas where hygienists and dentists do go into care homes. I'm still working with a lot of dentists across the UK trying to deal with this, and hygienists as well. There are some areas, but it's not across the board. So I think it is largely down to the care home staff.
Okay, thank you very much, Pat. I can't see any other questions for the moment, so I'm going to pass over to Lesley. Now, I incorrectly said Lesley was from Bradford University. She's actually from Bradford Teaching Hospitals. She is a senior research fellow in a department which focuses on older people and frailty, but obviously pain and frailty go hand in hand, as I think she's going to walk us through as she talks about her POPPY study, which I can't believe is in its 3rd year. So Lesley, over to you.
Okay, I'll just see if I can share the screen. Let's have a look. Oops, hang on. Slideshow.
Yeah, we've got your slides now, Lesley. That's great. That's great.
Right.
Do you want to put it to full screen? Oh, brilliant. It's full screen now.
See that? Just move this up. Okay. Okay, hello everybody. So my name is Lesley Brown. It's not Margaret Dunham. It's come up incorrectly from the link. And I'm the co-lead on the POPPY study, and this is actually the 2nd time that I've spoken to this group. And today I'm going to provide just a study update and just share some preliminary findings from the study so far. So the POPPY study is a mixed method study, which is being led by myself and Professor Anne Forster from University of Leeds. Co-applicants include Andy Clegg, who's a geriatrician and Professor of Ageing, Asim Suleiman, a GP with a special interest in pain, and we've got Deborah Antcliffe, a pain specialist physiotherapist, Professor Amanda Williams, who's a clinical health psychologist, Anne Rice, who's a PPI member, and Pat Schofield, Professor of Clinical Nursing, who you've just heard from. So we've got a good team mix. POPPY is funded by the NIHR Health and Social Care Delivery Research Fund, and we're just starting the final year of our 3-year study. So just brief background. Oh, slide's not moving. I don't know why it's stuck. Let me try it this way. Don't know why it wouldn't move with the button. So a little bit of brief background. Chronic or persistent pain is very common in older adults, particularly in older adults living with frailty. There is some variation in prevalence data, and that's partly due to differences in population samples and research methodology. And evidence from longitudinal studies suggests that unmanaged pain is associated with an increased risk of both incident frailty and of worsening frailty. And pain impacts on all domains of life in this population. And pain, or at least the impact of pain, is potentially modifiable for a lot of people if they are given the right management tools and support. Let's see if this works. That's working now. So the POPPY study aims to develop the content, delivery mode, implementation strategies, service support and guidance to enable older people with frailty to better manage their pain and reduce its negative impact on their lives. And it's a mixed method study with findings feeding iteratively into subsequent stages. And the study includes a literature review, in-depth interviews with older adults living with pain and frailty, interviews with healthcare professionals, and finally some co-design workshops with different stakeholders. And more details on the methodology are reported in the published protocol if anybody would like to find out a bit more. So for phase 1, we undertook a systematic review because we always do reviews at the start of any research project. And for this review, researchers identified multi-component pain management programs and psychological therapies that had been delivered in trials where the mean age was over 65 years. And we identified 31 studies that delivered interventions for managing pain or reducing pain impact in older adults. Now, none of the included studies reported the results within the context of frailty, unsurprisingly. Frailty is probably quite a new concept in terms of how it's kind of operationalized, so we weren't really surprised by that. However, team members have subsequently identified the studies that were more indicative to a population with frailty based on the study inclusion criteria. And information, particularly from those studies, will be shared in the co-design workshops. And we extracted information on the behaviour change mechanisms, the intervention content, the delivery mode and the personnel for those studies that was more indicative to a population living with frailty. So the full review of the 31 studies has now been published, and the reference, the link is at the bottom of this slide, which will be shared afterwards if anybody's interested. Now, for phase 2, researchers conducted in-depth interviews with 26 older adults living with pain. Most of the participants lived with mild or moderate frailty, and a small number with more severe frailty. Including people with more advanced frailty was really quite challenging. Some of them felt too unwell to participate, or they reported caring responsibilities, or just generally not feeling up to it. And this was despite the researchers offering flexibility and conducting the interviews at home. For those that took part, participants lived in varied locations, and they were from the northeast down to Devon, and we included older adults with a range of different living circumstances. And researchers have conducted grounded theory analysis. So researchers have developed a conceptual model with findings grouping into the themes reported on this slide. Themes included general health and well-being, the history or their story about their pain experience, and there was a lot of findings on the impact pain had on their daily lives. Now, researchers were particularly interested in their decisions to seek support or treatment and the barriers and facilitators behind this. And POPI's generated a lot of data. However, today I will limit to sharing a few slides on the topic of pain acceptance and their support-seeking decisions. So the study captured a wide range of experiences. Some participants reported coping very well with their pain and had strategies to reduce its impact, and there's learning to take from this group. Some considered their pain to be minor compared to their other health conditions or compared to other people, and comparing themselves to other people seemed to be quite a feature. A strong theme emerged about not wanting to overburden their GP or the health service, and a reluctance to seek professional support for as long as they considered their pain to be tolerable. However, some expressed sort of deep resignation about their pain and really appeared without hope that anything further could be done. And researchers noted that many of these participants were living with other health conditions, for example, diabetes. And for those other health conditions, they often had a really clear plan in place and could talk in detail about how they managed that. However, only a few of them had really ever been given any guidance as to how to best manage their pain. And it seemed to be that seeking support for their other health conditions was often their priority. So these next few slides, just to provide a snapshot of some of the experiences that relate to pain acceptance and their support-seeking decisions. Now, these are quotes from some participants who actually appeared to be managing very well. They understood that keeping busy and engaged in activities was useful and effective, and the group did not need or seem to want any additional support. And as such, not all old people living with pain and frailty will require additional services. However, some participants appeared to be coping less well and seemed very much more resigned to living with their pain. Some appeared to have given up hope that they could be helped. And being resigned to pain did seem to be quite distinct to being more stoical about their pain. Some participants appeared to be very stoical and considered themselves to be the type of person who tolerates pain without complaining. And stoicism and that idea of not complaining did appear to feature quite a lot. Now, many participants wanted to avoid overburdening the health system, and this was a current theme expressed by a number of participants. And an awareness of long waiting lists to access services was also raised quite a lot. And these are just a couple of quotes as examples of that. And this slide provides some summaries of findings around their support-seeking decisions in relation to discussing pain with their GP. Now, just about everybody had something to say about that interaction or lack of interaction with their GP. Most participants had discussed pain with their GP at some point, but often it was years ago and at the end of a consultation for another health condition. The challenges of getting appointments was raised a lot. Also wanting to be able to discuss multiple health concerns, including pain, within one single appointment. Some proposed that medication was all their GP would offer, but considered it not particularly effective, and there were concerns raised about side effects. Only 2 participants from those interviewed for this study had attended a pain service. However, some had been referred to other services such as physiotherapy. Actually, very few participants had any awareness of pain services. Most had not heard of pain services at all. Now, with the help of our very lovely patient and public involvement group, we've developed some case study vignettes or pen portraits from interview transcripts with the older adults. And these examples have been used during interviews with healthcare professionals, and I'll come to that next. And they've been used to generate conversations and to find out how healthcare professionals would work with a particular person presenting with both frailty and pain. And they will also be used in the up-and-coming workshops. Now, for phase 3, researchers have conducted interviews with healthcare professionals, predominantly working in a range of different pain services. Now, this has been to explore barriers and facilitators to including older adults with frailty within different service contexts. We sought to include different service types, mindful that pain services are delivered in various formats and across various settings. And as such, we included services with a third sector and voluntary sector input, as well as a non-NHS provider. Now, older adults have not typically been the focus of pain services, I think it's fair to say, and particularly the more specialist services. And this was confirmed when we looked at the mean age of those attending the included services for our study. And the age was more likely to be around a mean age of 50s rather than the population of 70s and 80s, which we were looking at. However, some services were proactively attempting to really meet the needs of older adults. One specialist service we included had developed a bespoke multi-component pain management programme specifically for older adults, and they were attempting to meet their needs via shorter sessions and topics more pertinent to that population, for example, topics on retirement. Another service, Rethinking Pain service, which is a Bradford Keighley service. Now they include third sector provision, and this service provides 3 tiers of support. Tier 1 focuses on information, which can be provided either online or in a community setting. And Tier 2, which utilises health coaches to enable people to access community groups, classes or resources. And as such, they can tailor support for older adults with frailty if they're actually referred to them and make it through their door. And we also included 2 generic community services. These services regularly include older adults with frailty, and we wanted to see how they might support older adults presenting with frailty and pain. And these services were generally including community matrons and occupational therapists. So overall, we've actually included 44 different personnel across a range of occupations, but we've tried to reflect the particular services that we've engaged with. So the phase 3 analysis is still underway. However, I am happy to speak to this group later on in the year if there is any interest in finding out about our phase 3 findings. And then our phase 4 workshops are starting very shortly. During the workshops, researchers will share findings from the earlier phases and start to think what a good pain and frailty service would look like, but within the context of different service types, mindful that we're unlikely to be able to reinvent the wheel and that there will be limitations in different areas. And within the co-design workshops, we'll be looking at things like referral methods, agreeing on personnel, the duration of appointments and how long somebody should stay in and attend a service. And following on from the workshops, and I think we've got about 6 workshops in total planned over the next few months. Following that, we've got some input from a health economist who's going to help us cost up various different scenarios pertinent to the different service contexts. And then finally, so the output for this, there's no single defined intervention. It's guidance, which is going to be tailored to different stakeholder groups, be it healthcare professionals, commissioners, older people's organisations. And we'll include, for example, case study examples of what it's like to live with frailty and pain, and examples of some services that we think are currently meeting the needs of people living with pain and frailty, and how older people should be identified and referred, and how we can optimise take-up for this group, and recommendations for the components of what a good service might look like. And my contact details are on here. I'm happy to answer any questions now, or you can email me later afterwards. Right, I'll try and stop sharing.
Thank you very much, Lesley. That was another really interesting talk. And just an observation about both projects. Basically, older population isn't homogenous. We're looking at an age range from 60 plus, and the thing is, our definition of aging is evolving. People are getting younger, but the pension age is getting higher. So it's interesting. This is going to impact on people who are still part of the working population, and we're going to class them as old. And there's a whole kind of blurring of that. But also, how can we compare and contrast what's needed for people who are 60, 65 to those that are 95, 100 plus? Yeah. Yes.
Yeah, interestingly, Margaret, on that point, I did some work in care homes many years ago when I was up in Sheffield, and talking to residents in care homes about pain in general. And it was interesting that the 65 to 75-year-olds had very different perspectives to the 75 to 85-year-olds. So that younger cohort expected analgesics and medical intervention, where the older cohort didn't want that. So they're not homogenous, and they are a changing group as well. So, you know, your 65-year-olds will be moving up the age, and the 55-year-olds will be going into that cohort. So.
Yeah. Thank you. Thanks. But I think, Lesley, you want to come back in there? I think you mentioned the Stoicism. I think that possibly links with that as well.
Yeah, yes, indeed. I think it probably does. But my point actually I was coming in on was your point about aging not being a homogenous group. And I guess one thing with the advent of the electronic frailty index, which is now embedded within general practice patient records, means that older adults now can be identified for services based on their frailty status rather than their chronological age, which is probably more of an accurate indicator of the kind of appropriateness of particular services, because as we know, somebody at 85 may be fit and running marathons, or, you know, be in great need. And I think the advent of considering people more through the prism of frailty, although the term isn't always very popular with people, is potentially more useful when thinking about services than their age.
That's a really, really good point, Leslie. I couldn't agree more. Considering people by their physiological age rather than their biological age, if that makes sense. So how much wear and tear, as opposed to, again, there's the societal disparities, aren't there? The whole thing about health inequalities. Anyway, we do have a question, question and a point in the chat, and that is, would it be useful to give patients interaction skills when seeing healthcare workers? And before you answer that, I was going to say it sort of links in nicely to the healthcare workers. They need the interaction skills, possibly as well, the complex communication skills, which possibly are lacking in some healthcare training. But over to you, Lesley.
No, it's a really interesting point, actually. I've actually, my sideline from interest in pain is actually on hearing loss. So, and I'm often quite shocked, actually, by the sort of interaction that some healthcare workers have with patients sometimes, and not real understanding that often, particularly older adults, are also living with maybe some low vision and poor hearing as well, sort of to add into the mix. I'm just looking at that question. How best to prepare seeing healthcare workers at appointments. One of the specialist pain services we were working with, they actually did some work with patients to prepare them for going on to a pain management program, which was quite interesting. It's just one of the services mentioned that to sort of get them prepared for their pain management program, which I thought was quite useful.
Oh, that's interesting. It's Pete who's put the comment in. He's also said social prescribers and social prescribing, I suppose, is useful to think for older people in particular. The social disadvantage and poverty that can be associated with old age, I suppose, are also factors. And he also comments healthcare workers have poor communication skills. There is a big tranche of education that needs to be in place for both managing older people to stay independent because of their frailty, supporting their needs, giving them the confidence sometimes to keep moving, but also they're also thinking about the education that needs to go on and the support for people with the dental concerns in care homes. Just because somebody's in a care home just means that they actually may have less access to their GP and their dentist than they would have had if they'd still been living in the community. So yeah, I don't know if anybody else has got any more questions they want to put in. Okay. Well, I think these are both really very interesting studies. I'm hoping, Lesley, that you will be able to come back at a future webinar and perhaps share some more information about your study and the next stages when you get more findings, particularly from stage 4. And I will hope it will feed into bigger projects. The thing is, the aging population isn't going to go away. So we really need the evidence base to ensure that the treatment is there, but also lobby our regional providers, governments, etc. I say governments because we have different delivery regimes in parts of the UK to ensure that the provision is there for our population. And the focus isn't primarily on an emergency service, it is actually on keeping people healthy and independent. And being independent also involves your teeth, because let's face it, if you don't have your teeth in, you're not going to want to go out. I would think of aging populations, think of my own grandparents and older people who wouldn't leave the house if their teeth weren't in, because they would feel socially disadvantaged, embarrassed. So there's a frailty and mouth and oral care are really, really important issues that are underrepresented in the literature and need to be carried forward. So thank you. Manfred saying thank you very much for this. The presentations are being recorded and will be available for you to access. Lesley, have you any final thoughts? I think Pat has to leave us very shortly, but have you any final thoughts on this topic of our ageing population and pain management?
No, just good to see that there's some interest in the topic and a few of us fighting the corner for it, really. Yeah, let's keep pushing forward and highlighting the area, really. A lot of older adults, I think, are very resigned to the pain, very stoical about the pain, and I think it'll be interesting to see what emerges from our co-design workshops. But I think they need to know that it is acceptable to speak to healthcare professionals about their pain and to seek support for it, because I get the impression that many don't.
Yeah. And it's okay to ask for help. I think that's what we have to say quite loudly. And our care home colleagues, I don't know if we have any care home colleagues on the call as well. It's really important that we support them, because our care homes are finite at the moment. And as I started off with, the ageing population is not going to diminish, it's going to get larger. I'm not quite sure. Pete said something about don't forget to include the CC today. Of course, the captions, of course, the closed captions. I believe there will be closed captions. Exactly. That's great. Thank you very much for that, Pete. That's very helpful. But I was just trying to say that the ageing population that we have, if we follow the model that's happening in India and China and other parts of the world, you know, it's rather scary. We are not at replacement with a young. We're not going to have the workforce that would be needed if proportionately older people were all in need of institutionalized care. So we want everybody to be healthy for their sake, but also for the sake of a good life experience for everybody. Quality of life is very, very important across the board. So thank you everyone again for joining this afternoon. Do hope to see some of you in the Pain Society ASM in Nottingham, but if not, do pop along to the website and see what we have available for you. There are maybe other resources, but this will be available on YouTube for you to access. Thank you again very, very much to our contributors today, Professor Pat Schofield and Dr Lesley Brown. And saying farewell from Margaret Dunham from the British Pain Society's Older People Special Interest Group. Thank you.
Thanks, Margaret, for organising.
Thanks. Take care.
Bye.
Bye, everyone.